Good morning. Welcome to the 7th Annual Community Health All in Chicago Breakfast Summit. My name is Laura Cerisi Starr, and I am the Director of Development and Communications at Community Health. Community Health is the largest volunteer-based free health center in the United States. We provide primary and specialty care, prescription medications, mental health and dental services, health education, and lab testing, including COVID testing and vaccines, on the west side of Chicago. Our patients have no health insurance, and we provide all of our services to them at no charge. We do this with the support of over 1,000 volunteers, partnerships with dozens of institutions, and donations from generous people like you. Thank you for being here and for supporting Community Health. I would especially like to recognize our many sponsors who are supporting this year's All-In series, including Baxter, AbbVie, Lundbeck, the Joseph and Bessie Feinberg Foundation, West Monroe Partners, and many others. I encourage you to visit our website, allin-chicago.org, to see the complete list of speakers, read the bios for our incredible speakers, and check out the rest of this month's events. Finally, I want to recognize this year's All-In Executive Leadership Council. We have the privilege of having 4 outstanding leaders serving on the council this year. Their great insights and support have been instrumental in bringing this year's series to life. Thank you to Dr. Bhatt, Mark Ishog, Brian Marcella, and Dr. Julie Morita for your contributions this year. You will hear from 3 of the members of our Executive Leadership Council today. The goal of the All in Chicago series is to bring together leaders from many different industries and segments of our population to talk about how we can work together to ensure every resident has access to the right care, in the right place, at the right time. Community Health has been hosting all-in events discussing access to healthcare in Chicago since 2015. This year, as we continue to navigate a global pandemic, the conversation around access feels as relevant as ever. COVID-19 has brought on many new challenges to leading our healthcare organizations and our home lives. Our panel today has been meeting and overcoming these challenges in the impressive ways they have done their entire careers. It is my pleasure now to introduce our host for today's conversation, Brian Marcella. Brian is the Market President Midwest at Cigna. Thank you, Brian, for hosting today's Breakfast Summit and for all you've done to help us plan a successful all-in as a member of this year's Executive Leadership Council. So with no further ado, I will hand things over to Brian.
Well, thank you, Laura, and thank you to everyone that has joined the presentation today to really dig into a very meaty and important topic. I too want to welcome you all to our 7th All-In Chicago Breakfast Summit. As Laura mentioned, my name is Brian Marcella, and as a member of the 2021 All-In Chicago Executive Leadership Team, I also have a unique view of the many sides of healthcare from my day job as Cigna's Midwest Market President, as well as being the board chair of Erie Family Health Centers. As many of you have seen, as I have, the ongoing COVID-19 pandemic has affected us all in numerous ways, but it's especially highlighted deep inequities in the health of our communities and the care that different populations are able to access. Today, we'll be discussing the ways that a pandemic amplified certain gaps and inequities in our system and communities, and our panelists will also discuss next steps we can and must take as a city to reimagine public health in ways that our community needs. To date, the city of Chicago has fully vaccinated 66% of the population, which is pretty good compared to many others, but our current case rate of 443 cases per day. You know, like my friends at Erie, Community Health has been working to increase vaccination rates and the accessibility to our patients in the community. The Latinx and Black communities we serve have been disproportionately affected by COVID-19. But these efforts are working. For example, more than 61% of Latinx patients at Community Health are fully vaccinated. We will continue our efforts to bring more equitable care to all, especially during this time. As Laura did, I also want to recognize my colleagues on this year's All-In Executive Leadership Council, and I want to thank Dr. Bhatt, Mark Ishog, and Dr. Julie Morita for your contributions this year. Your great insights and support have been instrumental in bringing this year's series to life. To get us started, I now have the pleasure to welcome Dr. Clyde Yancy, Vice Dean, Diversity, Equity, Inclusion, and Professor in Chief of Cardiology at Northwestern University's Feinberg School of Medicine, to give our keynote address. Take it away, Dr. Yancy.
Hello, I'm Clyde Yancy, Vice Dean of Diversity, Equity, and Inclusion at Northwestern University Feinberg School of Medicine, where I also serve as Professor in Chief of the Division of Cardiology. Additionally, within Northwestern Medicine, I serve as the Associate Director for the Bloom Cardiovascular Institute. I've been deeply immersed in our experiences with COVID-19 clinically and with our research enterprises attempting to understand the burden of this disease, particularly the disproportionate burden. I'm delighted and humbled that my good friend Joe Harrington asked me to be a part of this informative series of all end events, this one being the Breakfast Summit. I commend those of you that are in the leadership of Community Health for the great work you're doing. You're obviously a part of the solution. As I begin to share these comments with you, I think it's very apropos to start by looking back before we look forward. I also want to embrace the subtext, that is COVID-19, the footprint of COVID-19, and what needs to happen next in Chicago. So let's start by looking back. In June of 2020, a series of disruptive perspectives appeared within the medical literature, this one in the New England Journal of Medicine, talking about the microcosm in which I existed in academic medical center, and really challenging us to understand how important it is to drive true change. That is to say, allow social movements to serve as catalysts. I won't encourage you to read all the text here, but I do want to lead with one sentence. Leading with action on issues of health justice has been a long-standing challenge for health professionals, who are often more comfortable with descriptive research as the main focus of intervention. Let me also carry to another statement. Naming racism was one of the most important charges for a committee formed at Harvard to address how best to incorporate social movements as catalysts for change. In so doing, the challenge of naming racism was sometimes met with defensiveness or silence. And finally, you can see my colleagues from the Brigham said physicians must engage with social movements if we expect to contribute meaningfully to improving health by addressing this social and structural determinant. I know many of you in the audience are physicians like I am. Virtually all of you are public health officials and are involved in healthcare. So something in this very poignant statement from June 2020 resonates. Let me continue this because I think this really is the call to action statement. This was in the August magazine of exploratory discovery, otherwise known as Science magazine. And this is from the editor, H. Holden Thorpe. Look at these really priceless words. And then science and scientists finally need to listen to and make space for people of color. So laboratories that publish great science and produce influential scientists run institutions and their scientific units. And as you go on, you see that there is a companion statement from a very prominent African-American woman who is a creative scientist. And she says, how much creativity are we leaving on the floor because science repeatedly fails to come to terms with our narrowly defined processes and our limited ways of determining success. Now, why am I starting off with a commentary about the necessity for change and about owning that necessity for change in science? I am doing so because of what we've experienced. The pandemic was painfully disproportionate as experienced by communities of color. This is one of many websites that aggregated data. This is the American Public Media Research Lab website. I followed it very carefully for about 12 months because every 2 weeks there would be an update that would be quite appropriate. The last time it was put together, it really identified what Amanda Gorman so aptly described in her prose, in her poetry, when she said we brave the belly of the beast. it really was very appropriate for us to understand that particular context. Now, why do I endorse this experience of braving the belly of the beast? Because from that same research lab website, we find these important findings. If you look at the aggregate influence on Black Americans, on Latino Americans, on Indigenous Americans, decidedly disproportionately felt 1 out of every 645 Black Americans has died due to COVID-19. This website underwent a pivot in March of 2021, and that pivot began to look at the percent of those receiving at least one vaccine. If we look at the people receiving one vaccine, at least one, we discover that those who were most impacted by COVID-19 were least likely to experience vaccination. Lots of reasons to go into this, but it really does set up a very important point of discussion. But let's carry this forward, because now we see information that appears to be much more enlightening, much more uplifting, that not only the vaccination differences, but also the mortality differences appear to be narrowing. This was an important headline within the medical press just within the summer of 2021. It is because of this observation, though, that this conversation is so important. We are no longer on a downward spiral from COVID-19, but rather an upward spiral. This is a depiction of the known variants of the novel coronavirus, in particular B.1.617.2 is the Delta variant. It was minimally present, if at all, in May of 2021, and it is now the predominant variant, 90% in August of 2021. The color code tells a very compelling story, and even though the vaccinations are effective against the Delta variant, because it's so much more contagious, it is becoming a driver of disease. Now, as we're having this conversation as an informative dialogue with the All In educational series, it's important to go back and look at where we were and where we are with regards to race ethnicity. We now look at just one dose. The panel on the lower left shows that non-Hispanic whites, Asians, are experiencing an appropriate amount of vaccination, at least one dose, well in excess of 50-60%. Fully vaccinated is different. These are data from December of 2020 to August 23rd of 2021. This is the challenge we face, getting a sufficient representation of the population fully vaccinated, again, leading with regards to the non-Hispanic whites and Asians, but with Black, African American, Hispanic, Latino making up some important ground. We now look at the entire United States and think about people that are vaccinated. 171 million fully vaccinated. That's a big number, but the population is even bigger. And it leads us to a certain vulnerability. Fully vaccinated just through August 22nd of 2021, CDC data, so verifiable, is only 51.5%. From the beginning, we thought we would need at least 70% to have that phenomenon of sufficient protection that we could quell the virus. Some called it herd immunity. We don't use that phraseology anymore. So you can see the space we still need to cover. If we now look at something very important, and I'll get to this in a few more minutes in a different context, but the social vulnerability index is a way that we can precisely measure the extent to which a community is either resilient at times of great crisis or stress like a pandemic, or is vulnerable. Specifically, since this organization, that is CommunityHealth, is couched in West Garfield Park, this is a very applicable conversation. By shades of blue on this graphic, we can begin to see the communities where the social vulnerability index is either most vulnerable or most resistant. Here's the scale that we've depicted. If you look at the social vulnerability index, closest to 1 are areas that are most resilient, and closer to pale blue is the areas that are most vulnerable. So you can see what's happening in our own state of Illinois and how this is varying. The color you want is deep purple because that's where the most people have been vaccinated, and it corresponds with their social vulnerability index. I've highlighted specifically Cook County, and this is with regard to community transmission. There's only one county in all of Illinois that isn't subject to the highest level of transmission. So what am I telling you so far? I'm telling you that in 2020, we experienced a disproportionate burden. We have effective vaccines, but we've not yet had sufficient immunization. I'm demonstrating to you using real data that the new scourge, if you will, is a Delta variant. I'm showing you that it is particularly prevalent in Illinois, especially in Cook County, and that the extent to which we see adequate vaccination varies directly with the social vulnerability index. Now let's take this to the next level. Let's think about cases on a weekly basis as a function of race, ethnicity, which I've highlighted here. Again, CDC data. You will recall very clearly in the spring of 2020, the pain, the disproportionality experienced in communities of color was striking. As you follow the curves out and you see the peak in the winter of 2020, and then begin to look at the nadir in July of 2021 when we rejoiced and thought this was all done, now we see the cases have gone up again. We no longer see the splay as a function of race, ethnicity. Instead, what we see is this clustering, and that's because we're looking at a pandemic in the unvaccinated. But if we go beyond cases and begin to look at deaths, we see something that is sobering and reassuring. We knew all along that the burden of death was highest in communities of color, and that is redepicted in this graphic. But now we see that the burden of death is similar, and thankfully it is lower. So again, it shows that the vaccines have helped, but we still are experiencing death in a way that I think is unacceptable, particularly since it is avoidable. With all of this having been said, in April of 2020, we put in writing in the medical literature that COVID-19 and the experience in the African-American community was a bellwether event. It clearly identified the necessity to fully address healthcare disparities. So have we done that? Looking forward to 2021, perhaps the most important thing we need to address is this new intersectionality of race and medicine. It starts with bias. What is bias? If you look at this, this is a fairly straightforward optical illusion. You see 4 pieces of timber at 3. But it's not so straightforward when you go through these images. When you look at how these images make you feel, you recognize that we are processing information and we're having visceral eruptions, if you will, based on the revisit of some of the most heinous images from 2020 and then from January 6, 2021. We could have processed everything we saw with sadness and despair, or we could have processed it with a notion of freedom of speech, the right to bear arms, social justice, and Black Lives Matter. Importantly, we all process information by either very slow cognitive networks or very fast reactive emotional networks. And this really governs not only our thinking, but our behaviors. So what I'm getting to is that we all function with a kind of bias that is ubiquitous throughout all of us. It is informed by individual experiences and perceptions of others. This plays directly in the disproportionate burden we saw of COVID-19 in 2020, and we are at risk for the same thing going forward in 2021. That is to say, the healthcare disparities that were made so evident by COVID-19 are still a concern. What are disparities? Those are differences that are not attributable to clinical appropriateness or need, but rather reflect shortcomings in systematic structure, biases, and prejudices, because we know that when there's equal access to healthcare, the quality of health still varies according to minority status. Non-minorities experience a better quality than minorities. These disparities then become the key consideration for the rest of my conversation. It's important that this critical definition enter the dialogue: racism. We all operate with some definition in our mindset of what racism is. I've depicted one here, but I want you to appreciate the multidimensionality of racism and focus on the contrast between the personal racism that many of us may have experienced if we're old enough and if we're from communities of color as we were being acculturated, versus institutional racism or the presence of barriers. This is my own commentary about what it felt like as a child growing up in a deeply segregated environment. And I'll pause for a moment and let you digest these words. But as we go forward, this is where it matters in medicine. When a practitioner is engaging with a patient, uploading objective data, and then making a critical interpretation of the data and decision on intervention, if that context is healthy with a good appreciation for that patient, then the ultimate decisions are green stars and blue stars. But if that context is not healthy and it's influenced by bias, by prejudice, by racism even, then the decisions are less favorable. You can begin to see where all of this is coming together. We saw decision-making, we've seen decision-making in the way communities are configured that at a minimum must be attributable to some kind of thought process that enables some communities and limited other communities. At the community level, then how do we measure this vulnerability? And I told you I would come back to this notion from the Social Vulnerability Index. This is an index that is aggregated from 15 US Census variables. And again, it identifies any score close to 0 as lowest vulnerability or highest resiliency, and any score close to 1 as highest vulnerability and lowest resiliency. And you can see what the stresses are that bring out this sort of experience. This is a map that you've seen many times over. I'm showing you Chicago, and the cursor is in Streeterville from where I'm giving you this presentation. Here in Streeterville, we have the lowest vulnerability and the highest resiliency, so the score is close to 0. Move the cursor just 10 miles south, and you see now that the Social Vulnerability Index is close to 1, meaning very high vulnerability and lowest resiliency. How does that matter? It matters in this way. If you think about the disproportionality that we and others put in print about the experience in Chicago, you look at the COVID-19 cases by zip code. You see the west side zip codes and the south side zip codes. That was the aggregate of the fatalities seen during COVID-19. Overlay this map now with the social vulnerability indices, and it's a complete mirror image. Take it the next step and add in now the evidence of death, the zip codes at risk, and the social vulnerability indices, and you begin to see a story that's hard to ignore. You begin to see that there is something unique about place that puts so many people at risk. So how do we bring all this together? I have a definition here for you about structural racism, something that is a trigger phrase right now, but if we think about this academically, it's less a trigger phrase and more an informative statement. This is a system in which public policies, practices, and representations and other norms work in various, often reinforcing ways to perpetuate racial group inequity. It's been said that the greatest evil is not done in places where persons of ill repute are gathered, but rather in clear, carpeted, warm, well-lighted offices, decisions made by men who do not need to raise their voices, meaning that the barriers are real, but people put together the systems that led to those barriers. And that's what we are calling an uncomfortable truth. And that's what we believe is happening in Chicago. Why? Because of this phenomenon of redlining. Some have even argued that Chicago invented segregation. This home owner loan corporation was a product of the New Deal after World War I, trying to influence housing in a positive way and overcome housing deficiencies. The plan was simple. The federal government would back the mortgages after the communities received a grade of creditworthiness, but those grades were disproportionately administered, and communities got a D grade were literally outlined by red lines, the adjacent communities by yellow lines. If you look at this map of Chicago from the 1930s, you can see the communities that were red line, yellow line, and the story becomes pretty self-evident. You can also see that because of segregation, instead of residents moving to communities with better creditworthiness, there was a reverse migration where more African-American residents went to those red line communities because of segregation. And now this same map I showed you, where the deaths from COVID-19 occurred, where the at-risk zip codes occurred, and where the poor social availability indices occurred, meaning that a policy put in place 90 years ago may be the root cause of what we've seen during COVID-19. That's a lot to digest, but one more thing I want you to digest. From where I give this lecture, if I were to travel to the South Side at this moment, I'd step outside and get on a train, and every mile that I traverse, life expectancy would fall by 5 to 10 years. Ironically, that train is the red line. So that Chicago's earned. What are the solutions? Well, the first solution is that we have to understand that we must deal with these tragic statistics that we believe are due to decades of adverse social determinants of health. Many have argued the case for self-sufficiency, and we don't disagree with that. But people must have good choices so that they can make those choices. If there are no good choices in their community, then the argument for self-sufficiency falls on deaf ears. How do we overcome disparities then? We have to address public policy. The solution is to consider all policy as having a health consequence. So by default, all policy approximates health policy. So how do you and your respective institutions and your teams participate? First, overcome your own implicit bias, regardless of your demographic. Be willing to consider a different perspective. Be willing to think unconventionally and check your assumptions at the door. Second, build an anti-racist culture. I'm a cardiologist, and in my field of cardiology, we're talking about this. We're talking about how do we create an anti-racist culture? Who do we recruit? Who do we train? How do we promote? What are our day-to-day activities? What happens on a personal level, the way we engage with each other? All of these things lead to an anti-racist culture. And then what about diversity? This is not about representativeness. It really is about a path towards excellence. There are many lessons learned from corporate America, and one starts here. This is from the Harvard Business Review. An inclusive environment led to employees that were nearly twice as likely as others to achieve value-driving insights. If we now go to Deloitte and Touche, the case for an inclusive culture, organizations with inclusivity twice as likely to meet or exceed financial targets, 3 times as likely to be high performing, 8 times more likely to achieve better business outcomes. And you've got to love this graphic from Forbes. If you look at the decision-making outcomes of teams that are all male and all white, 58% of the time, those decisions were deemed to be appropriate. This is a post hoc assessment. But if then you go to gender diversity, then age and gender diversity, then age, gender, and geographic diversity, the number goes from 58% to 87%, demonstrating there's an association with excellence as you embrace diversity in all of its iterations, as teams, as leaders are making decisions. And this is the way that we generate policy that changes it. So I've shared quite a bit with you. I took you through what happened in Chicago in 2020. I've taken you through some very important definitions of bias, of disparities, of racism. I've shown you a key example of structural racism as it impacted the city of Chicago. I began to demonstrate some steps going forward. Check your assumptions at the door. Understand how important it is to build an anti-racist environment. But what else needs to be done in Chicago? I can't emphasize this enough. Vaccinate. We still have a deficit in those that have been fully vaccinated, particularly in communities of color. Educate. Overcome the fallacies, the myths, the things that are limiting our own citizens from proceeding forward to receive vaccinations. They're safe, they're effective, they work. Advocate. Advocate for policy change. Advocate for changes in the community. advocate for more organizations like Community Health, and then vote. Because remember, all policy ultimately is health policy, because poor public policy almost always has a health consequence. And then what else do? You repeat all the above until change happens. Again, it's been my pleasure to visit with you and be a part of the All In educational series and to support community health. Thank you again for the invitation.
Well, my thanks to Dr. Yancy for his very powerful presentation, which further opened my eyes to the intersection of race and medicine. And now this brings us to the conversational portion of this morning's event, and we'll dig much deeper into what we can do to impact these health disparities. Just before we get into that, one quick housekeeping item. This conversation is happening live, so please be sure to submit your questions for our panelists. We'll do our best to answer as many as possible during the next hour or so. And you can just submit your question using the Q&A button at the bottom of your screen. With that, it's my pleasure to introduce our moderator for today's conversation and Community Health CEO, Steph Willding. Steph, thanks for being here today and for taking leadership on this important topic. Please help get us educated.
Thank you so much, Brian. Before I have the pleasure of introducing our panel, I just wanted to note I've got some construction taking place outside my office. For those of you joining outside of Chicago, you should know we have 2 seasons, winter and construction. So please forgive any noise. And now it's my honor to introduce our panel today. Dr. Jay Bhatt is a public health physician who has worked at a national and local level to improve outcomes for vulnerable populations, including by strengthening the design and delivery of care and public health. Currently, Dr. Bhatt is a practicing physician. He's also the Chief Clinical Product Officer at Medical Home Network, More Care, and he has consulted on COVID-19 response for the Illinois Department of Public Health. Dr. Julie Morita is the Executive Vice President of the Robert Wood Johnson Foundation, where she oversees programming, policy, research, and communications activities. Recently, Dr. Morita has served on several federal, state, and local COVID-19 advisory committees, including the Biden Transition COVID-19 Advisory Board. Israel Rocha was appointed as the Chief Executive Officer for Cook County Health in October 2020 by the Cook County Board of Commissioners. Before arriving at Cook County Health, Mr. Rocha served as the CEO of NYC Health and Hospitals, Elmhurst and Queens Hospitals. This hospital system is the largest public health system in the United States with a combined annual budget of over $8 billion. And finally, Dr. Nick Terheyden is a physician leader and business strategist who draws on his clinical experience, technological prowess, and relationship management capabilities to craft and implement transformative, patient-centered strategies aimed at improving operational performance and efficiency. Currently, he is the digital health leader and principal at ECG Management Consultants. Please join me in welcoming all of our panelists this morning. Now, before we get started, I want to remind everyone in the audience watching that you can submit questions for our panelists using the Q&A function right at the bottom of your screen. You can submit these questions at any time during the session, and I'll do my best to make sure that your question is answered. So kicking things off, Israel, equity these days can sometimes feel like a bit of a buzzword. It's something that we hear a lot, but in your experience, what have been the very real impacts of inequity in the healthcare system, and how does structural inequity and structural racism show up in healthcare today?
Sure. First, I want to start by telling everybody good morning and happy to be here with you. And thank you so much for convening this forum. I think the impacts of inequity are numerous. And I think that most of them are not only limited to traditional healthcare issues, but they manifest itself in our health and well-being as individuals and the way that we live our lives. Premature death due to chronic conditions are usually often things that we can see. They're a combination of comprehensive healthcare coverage, food and housing insecurity, and other socioeconomic factors. Our institution for over 185 years has been a core entity in helping to drive change in healthcare here locally in Chicago and across the country. But I think when we hear the words about inequity, structural, and how did we get here, this hasn't happened overnight. It's a history and a way that we think and approach healthcare. And really, it even goes back to other institutions in education and others. I think when we think of the word equity, we have to think what it means. And it means equality of access. And it's not just access, but equality of care. I think part of our problem has been that we think that if someone has access to a clinic that they have to wait 10 hours for to see medicine or to get assistance, that's equity. That's not equity. Equity in our country means that when everyone across the country, regardless of your circumstance, has the very best healthcare has to offer for you as an individual. Equity also doesn't mean that everybody gets the type of care that is provided to the most affluent, because their needs are different. What equity means is that the very best resources for whatever you need as an individual is available to you. And I think that is where we will start to make the changes. Structurally, our country has to overcome a lot of things, and we've been making great strides, and we have a much greater path to travel. What are some of those structural inequities? For a long time, our country produced drugs and vaccines and manufactured doses that left out minorities completely. And then we had to adjust dosing patterns. There were challenges. There were drugs, including things like Tylenol, that didn't work as effectively in women because they weren't part of the trial. There were drugs that left out minorities. That has changed. Most excitingly and most recently in our vaccines, they have actually incorporated a diverse group of individuals where all people throughout the world were included in the trials, every composition, every individual. And what we saw was very safe and effective vaccines that have helped serve and stem the tide of the pandemic throughout the world. And I think that is what can happen when we address healthcare, that we can really make those differences. So for me, equity means that there is a commitment to excellence to ensure that everyone gets an individually tailored health care plan, has the access, the availability, and the means to ensure that what they need most in their life to be the best person that they can be, to live the healthiest life that they can live, is available to them universally. And I think that when we get that universal access for patient care with the follow-up of the availability of all resources that they need, that is when we have achieved equity. When we address it in our systems to ensure everyone's included at the table when planning healthcare, that's when we have helped reduce the structural challenges we have today.
Thank you so much, Israel. Jay, can you share a little bit about in your practice, who are the people that you see as being most impacted by the inequities that Israel just described? And how does intersectionality present in this?
Well, good morning, everyone. Thank you so much for this opportunity to be here, and it's an honor to be with this esteemed panel and serve on the Exec Leadership Council. And I think Dr. Yancy and Israel laid out really well the inequities we see laid bare by COVID-19. And it's racial and ethnic minority populations that are disproportionately represented among essential workers and industries, which might be contributing to COVID-19, racial and ethnic health disparities. And these are folks I see in my community health center on the south side of Chicago, that I see in supportive living facilities and nursing homes and long-term care as vulnerable older adults. We have to realize that I think also this is a community of people that are physically, socially, and cognitively worse off than they were pre-pandemic. And so they may be also in situations that are different and we might not expect and see so clearly. And so it takes a lot of effort and empathy and listening and engagement, speaking to the issues of racism and bias to uncover some of that. Now, if we dig a bit deeper, people who experience the following: discrimination and racism. Discrimination, which includes racism, can lead to chronic and toxic stress and shape social and economic factors that put some people from racial and ethnic minority groups at increased risk for COVID-19. But we also are seeing this by place, by people who are have disabilities, people who are veterans, between gender. We also see people that have challenges with healthcare access, care, and use. Lack of insurance, transportation challenges, childcare, ability to take time off of work, particularly if they're working 3 jobs. Just yesterday, I had a patient take 3 buses to get to the clinic, and how do we make that easier for them to engage in the system. Cultural differences, and at-risk occupations, which we know from farms to factories to grocery stores and public transportation to the service industry, healthcare. These settings can lead to more chances, certainly, of exposure if we're not doing the right things we need to mitigate them. And then we see educational and income gaps. That people from certain backgrounds with less high-quality education, literacy challenges, limited job options. Restaurant workers, for example, we saw 5,000 of the 25,000 establishments close in Chicago, and 124,000 of the nearly 600,000 workers lose their jobs. And unemployment is, joblessness of 8.7% in December, but more than twice the rate before COVID struck. So I think that these people have names, families, and lives, and they're really struggling not only with the clinical conditions, but place, environment, and mental health as a real barrier to trying to get to a better place.
Thank you, Jay. This was discussed a bit in the keynote by Dr. Yancy, but Julie, can you talk about what ways you have seen COVID widen inequities and disparities? As Jay mentioned, many of these communities are worse off than pre-pandemic. And specifically also, how has this shown up in vaccination rates? Expanding a little bit on Dr. Yancy's keynote.
Good morning, Steph. Good morning, other panelists, and good morning to the audience. It's really a pleasure to be joining all of you today. And I really want to, before I jump in and answer the question, just want to acknowledge the incredible work of Community Health, all the staff, the leadership, the supporters and the volunteers and the partners, because you provide an incredible service to the area, especially at a critical time like we're experiencing the past year and a half. So thank you for all the work that you've been doing and for bringing us all together today. Your question related to how the pandemic has really impacted health inequities and widened them and made them worse is really a critical question. I think we know prior to the pandemic, there were tremendous inequities that existed throughout the nation. And what the COVID pandemic did is actually it laid bare these inequities, but then also, which I think is incredibly important, is made clear that the connection between the structures and the systems that are in place that have contributed to these inequities being revealed, that it's not just a matter of individual choice that has led people to have these poorer health outcomes as much as the structures and systems that are in place that have led them to this place. And so when you think about the disproportionate impact that we saw in communities of color and low income communities in terms of death and hospitalization due to COVID, we could see the connection to their work and their living conditions, their inability to take time off, their inability to work from home, their inability to social distance and living in crowded conditions. All these factors really contributed to why certain groups were more likely to be disproportionately impacted by serious disease and outcomes. And so I think it's not only important to lift up the fact that these inequities exist, but what are the causes of these inequities? And then that helps us focus in on the solutions that we need to address. When we think about the way the vaccine has rolled out in particular, you can see how the existing inequities in healthcare delivery, inequities in addressing community needs really played out with how the vaccine was rolled out initially. The initial efforts were under-resourced and state and local health departments didn't have the dollars that they needed to really ramp up strong systems that would be equitable in terms of their distribution. And so when you look at the way the vaccine was distributed, it was the wealthy, it was our white population that was vaccinated first. And then our communities of color were really left behind. What we've seen is that there have been improvements over time because there have been resources that have been flowing to community to really ensure that the systems are in place to allow people to get vaccinated. So much attention was paid to vaccine hesitancy as a cause of vaccine disparities in coverage. And yet, when we look at what happened with the rollout of the vaccine, some of the challenges with communities of color and low-income communities and rural communities getting access to vaccine weren't related to vaccine hesitancy, but were related to inability to get access to the vaccines because the systems were online, or the clinics were scheduled during work hours during the week when frontline workers couldn't necessarily take time off from work, were located in places where our lower income communities couldn't actually access them easily through public transportation. So there were structures and systems that were in place that really contributed to these inequities. And so our existing inequities and structures and systems that were in place prior to the pandemic just really revealed the problems and made clear the problems during the pandemic. I'm hopeful that as we move forward and out of this pandemic, that we'll address these systems and structures. And there's glimmers of hope when we look at the investment in community engagement. So as we've looked at the way the dollars have flowed from the federal government to state and local health departments, a lot of those dollars are going to community groups to help address access to vaccination, access to health services, but also to address questions and concerns about the vaccines. Because in addition to the access issues, there are questions and concerns within community, and there's no better way to really address those questions than through the community organizations and trusted messengers within the community themselves. And so again, I think, Israel and Jay and Dr. Yancy all highlighted the inequities, the challenges that we experience. Really, as a way forward is really focusing on these structures and the systems that are in place so that we can be better than we were heading into this pandemic when this pandemic is over.
Julie, thank you. I'm so glad you brought up the issue of vaccine hesitancy and what that looks like today and the role that community organizations can play in that. Nick, at this point in the pandemic response, what role does persuasion play in increasing vaccination rates in the communities most impacted by COVID-19?
Thank you, Steph, and thanks to my colleagues and to the organization for putting this on. It is a privilege to be here, and I join with my colleagues and the presentation and all of the points that they've made. This inequity, from my perspective, has been amplified by a pandemic that nobody was essentially prepared for. And I continue to try and find the positive within all circumstances. It's hard in the case of a pandemic that has had such a huge impact on people's lives. But if I was to pull out a thread, it is the spotlight that has been focused on this inequity that I hope we don't lose the momentum and continue to sort of organize and address appropriately. When it comes to persuasion, I want to tell you a story. In fact, it's a recent trending topic that relates to this. There was a image of a nurse holding a sign that was shared. It was shared with approximately 44 million people saw this image, shared over 500,000 times. And she was essentially promoting, or the sign was promoting, that she didn't need to wear or have a vaccine because she'd worn a mask for 573 days, if I recall. And the reason I tell that story is that this is part of the mis and disinformation that persists throughout the social media that has also amplification effects. And we are struggling with this as scientists, as clinicians, as compassionate people that want to do the best by individuals. And we struggle with information that is essentially false. And the reason I tell that story is that it took an extraordinary amount of effort of an individual to identify the location, the individual, the context, to essentially ultimately disprove the majority of it. There were some strands of truth, and that's what we deal with on a daily basis. So when it comes to persuasion, I think what we have to do is to use all of the tools. And my personal favorite is walking a day in the shoes of the individual that is resisting. I start all of my conversations when I'm trying to persuade individuals with, what would it take to persuade you to take the vaccine, as an example? And if they can't answer that, ultimately it tends to imply that there is a very, very challenging path to ascend that ladder and persuade them to believe in the science that we all believe in, know is true, but are struggling with this disinformation campaign. The other thing that I would say is that we have to use the technology that's appropriate for the individual. And I'll pick an example here around telephones. I don't know about the panelists and the attendees, but for the most part, I don't answer the phone if my phone doesn't know who it is. And if we are outbound calling and failing to identify ourselves and rise above that level of spam, same is true in email that just never sees, we're struggling. So if I was to pick one thing, and it comes from other communities in other countries that have effectively used this, one of the most striking things to me is that 95% of text messages are read within 5 minutes and processed. So just the simple communication process that allows for that information to be disseminated so that people actually get to see it and receive it, for me, is one of the essential components of addressing this persuasion. You have to get the information and you have to address it from the perspective of the individual. There are so many opportunities, but more often than not, we miss them because we don't connect directly with those individuals.
Thank you so much, Nick. I want to turn our attention to a question that we got from audience member Mark Shields. Jay, I'm actually hoping you can weigh in on this. Access to care is just part of overcoming disparities. What are the best ways for healthcare organizations to engage in addressing social determinants of health?
Thanks, Steph. I think Mark poses an important question, and I think it builds on what we started with Dr. Yancy and building this sort of anti-racist culture, and it starts with leadership, making a commitment to wanting to do this, and then organizing the team and the resources to support that. And I think Nick also, along with Julie and Israel, highlighted that we're at a really important moment, and to make a shift to creating a movement that's sustainable around this issue, and a shift in public attitude about what public health is, the role that we can play to help support the health in their lives, and thinking beyond clinical medicine, but the intersection across sectors between healthcare delivery, public health, the private sector. And I would say this one is language. Language matters. So what are we talking about when we're talking about social determinants of health? So if you think of just the housing example, and we know that on average, unstable housing leads to 27 years less life expectancy, helping a patient of mine get housing they need that's stable, or addressing issues related to mold, is a social need. When we talk about social determinants, it's the lack of affordable housing in a community. And then health equity, or systemic or structural, is the policy issues that and the discrimination and that has led to decades of policies that have impacted this issue. So where do we want to intervene, and understanding where you want to intervene and what you're trying to do is an important conversation. So we often talk about them together, but they're three distinct yet overlapping constructs. The other is, I think, quality and equity. You can't, they're two sides of the same coin. Can't achieve quality without driving forward equity. And I think thinking about that, across our clinical work, across place-based work, environmental work. And I think that there have been steps that organizations have taken in working closely with other partners in the community, and understanding how do you build trust that's not just for the moment, but for the long term, and sustainable, and to the point of walking in someone's shoes. And one example I saw health systems do that's worked really well is community visioning, and being with the community and having the community tell them what the needs are. That has really led to an impact. And one example just has certainly in Chicago with the Presence Health System, but also in Richmond with Bon Secours, where the community told them that what really was the problem was jobs or another issue, and that led to a whole set of interventions that then positively impacted the community, not just economically, but from a health standpoint. So I think that's a place to start, but much more to do.
Thank you, Jay. And also thank you again to Mark for posing that question. As a reminder to the audience, feel free to pop a question in the Q&A section right at the bottom of your screen at any point during the session. I'd now like to turn our attention to be forward-looking and next steps. Julie, today we've discussed many of the structural inequities in healthcare. From your perspective, what, if any, of these inequities are you starting to see are finally being addressed?
Right, so Steph, that's an incredible question. And I think maybe it's important to stop and just think a little bit about what equity actually means in terms of its reach. I think when it's properly understood, what equity actually is a bridge to a better future for everyone in America. It's not just focusing on subsets of the population, but it's really for everyone in America. And when we think about achieving equity, what we're talking about is everyone in America, regardless of race, regardless of economic status, regardless of job, regardless of zip code, is actually able to do more than just survive, but actually to thrive. So if you think about that from an equity perspective, that is really the end state and the goal for us. And I think we all are better. And what the pandemic has made clear is that there's this interconnectedness that we all have, and interdependence that we have on each other. And so it's really in all of our best interest to help everyone achieve this level of health and well-being. What I was thrilled to see early in this administration was the acknowledgement of equity being important. And so having Health Equity Task Force included at the White House, to have health equity leadership by Marcella Nunez-Smith, I mean, these are all critical signs and commitments to really addressing equity throughout the nation. And that's the beginning of the work that we can actually do. I think the foundation ourselves, we're focusing on, increasingly focusing on addressing structural racism as it impacts health, recognizing this critical link that
I think we may have had a little bit of a technical snafu. So while we...
Equity.
Sorry, Julie, we lost you for just a moment, but welcome back.
Okay. Oh my gosh, I lost my train of thought.
You were discussing structural racism and how that's so key in our public health response.
Thank you for reminding me. Yeah, so I think as a result of that, one of the areas that we're particularly focusing .
So we'll go ahead and circle back with Julie here in a moment. Nick, I want to circle back to something you touched on a little bit earlier in the session, talking a little bit about text messaging versus calling patients to improve persuasion and information flow and all of that. So what role can technology play in reducing health disparities and closing health equity gaps?
Thank you. So as I think about this, one of the statistics that sort of impinges on everything from a technical supporting act for health inequity is the 37 million people in this country who suffer from inadequate internet access and inadequate technology. That is an extraordinary number that for somebody that has a laptop and has, fantastic internet connectivity is just almost unfathomable. So if we fail to address some of those fundamentals, and, it was a shame, Julie was talking about that and the work that's going on with the government and the addressing, and Jay mentioned this, in terms of those elements that we need to focus on. But we can start with basics. And, I mentioned text messaging, and I pull from Africa, which, has a special place in my heart. They have done tremendous things with very limited resources. And one of the things that I found in this country is sometimes a lack of willingness to look outside to other places that have achieved things. And they did this. I'll give you what for me remains one of the most compelling examples with mothers in remote African villages delivering babies, which is a perfectly normal activity for most, but there is a specific condition that requires medical attention, and preferentially they should be in the hospital. But for those individuals, it's a long trek and knowing where to separate. Simple process of using doulas or the equivalent of sort of midwives in that circumstance, scanning the individuals and sending it through the mobile network, very minimal bandwidth availability. It was read by a physician and a message came back with a simple text message that said, stay or go. And for that mother, that was important. She could stay in the village, not have to travel 3 days to the hospital and have the baby and, you know, have the support. But for the ones that were at risk, they would make that trip. We didn't save one life, we saved 2 lives, the mother and the baby, with simple text messaging. So using the available resources and adapting to the individuals that don't have access is an essential part of that technology. Now, obviously, in an ideal world, we would have all of this technology for everybody. I wish that were the case. I know I can't make it true immediately, but in the intervening time, we can allow access through technology that supports those individuals without smartphones and without, you know, widespread internet access.
Nick, thank you for sharing that incredibly powerful story. And I think it certainly reflects the experience that safety net providers have had on the ground as well during the pandemic and how we've used text message. Julie, I'd love to circle back with you. Apologies to everyone. As you know, the Zoom world has its challenges at times. But I think, Julie, you were touching on something that is so critical in the discussion and how we move forward now, which is how healthcare really deals with structural racism.
Yeah, so thanks. It's funny to come back into the conversation when Nick is talking about technology challenges after I lost internet connection. So thank you for tolerating my departure and covering for me. I think one of the key things that I would say is for healthcare organizations, a critical piece of addressing structural racism and is really engaging with community to understand what the community is actually experiencing. And Jay mentioned that earlier, that in order to really understand what the major challenges are for community is really to engage with them. We're currently supporting some work with Refugee Community Partnership, which really is looking at language barriers to people receiving care, high quality care. And an example very similar, somewhat related to what Nick shared, was an example of a Congolese woman who actually went in labor, and she brought her personal interpreter with her and requested an epidural for care. But unfortunately, the healthcare system did not recognize her personal interpreter as a contractor or an agent of the hospital. And so they didn't accept her request for an epidural for labor. And so she was denied that service. And so it lifts up an example of how the public policies are important, and hospital practices or implementation of these kinds of policies are really essential. And unless we do them in an equitable way, recognizing and cultural competence among our staff, we won't necessarily meet the needs of the community. So really having these kinds of engagements with the community to understand what challenges they're experiencing, what barriers they're facing to high quality care are really, really important. And so it's a matter of looking internally at our own practices within healthcare systems, but also looking externally in terms of the roles that healthcare systems can play within the external community that they're trying to serve. But a core component to that is really having community be a part of the decision-making and influencing decisions and policies and practices that are happening within institutions.
Thank you, Julie. And I want to ask one follow-up question. What role does representation play in this, and the importance of having medical providers and support staff, care team members that reflect the community, and how does that play into improving overall health outcomes in those communities?
Yeah, I think representation is a critical element in terms of really meeting the needs of community, both from a trust perspective, in terms of earning the trust of people, whether it's related to vaccine acceptance or whether it's related to maternal care or infant care. All these kinds of things are really, in order for people to feel comfortable receiving the care, they have to have trust in their people who are delivering the care, and having people that look like you or are from your communities really is an essential component. The other part of it is really having people who understand what's happening within the communities themselves. And that kind of knowledge and understanding can really influence the way policies are implemented, the way practices are established within institutions and organizations. And so I think it's really critical for there to be good representation within organizations. It's just critical.
Thank you. I want to turn our attention and bring this, nice theme here, bring us a little bit more local to Chicago. Israel, can you talk to us about how Cook County Health has adapted throughout the pandemic? And which of these changes do you believe will become permanent? And if you could also touch on a little bit of this theme that we're hearing amongst the panelists around what you're hearing from the community and what you're doing with that information.
Great. So I would say, much like other health systems, we had to pivot to a telemedicine model. We had to adjust our operating model and make sure that our workplace was able to protect our employees and patients while still rendering care to those most in need. Many of these strategies will evolve in the post-pandemic world. I think that telemedicine will finally take off as a means to make sure that we have medicine at the right place at the right time, and that we can be able to make it more available and easily accessible to individuals who need it in all places throughout the world and throughout our communities. I think staffing shortages have become critical and have been highlighted. And not just staffing shortages, but the training that our staffing needs to be able to competently respond to pandemics and where we need those staff. What are the key areas that were highlighted of shortages in physician, nurses, even clinical support staff throughout our organization. We need to ensure that our employees are safe, and we need to make sure that we have an adequate supply of those providers to care for our patients, especially at a time when things like COVID-19 hit our communities. We also need to make sure that we require the COVID vaccine throughout our community, and something that is being pursued aggressively throughout our area. And not just a COVID vaccine, but that we're also being able to launch substantial research in finally being able to come up with a broad spectrum antiviral entity. We have been plagued now since the 1800s to today with ongoing viruses that continue to move forward. The way that we have been able to split the atom and put a man on the moon should be the kind of effort that we should take forward in creating an antiviral universal agent that will be able to finally push back the study of virology to a place that we can overcome. We've been able to do it with bacteria and with other pathogens. I think the space and the time to be able to do that and finally be able to get viral infections under control is something that we need to invest as a community. And I think that this has finally highlighted how vulnerable we are without a substantial investment. Same thing with the moonshot approach on how we can have broad spectrum antiviral agents available that can combat some of these critical illnesses that we confront. In addition, I think that the traditional role of a healthcare provider, we have pivoted to creating new types of services. So as a public health system, we opened and created very large public vaccination centers throughout our suburbs and our communities. We used things like the COVID vulnerability index to determine where those needed to be, and we made them broadly available to individuals throughout the country. And I think you have seen that here in Cook County, even though we are one of the most diverse counties in the state of Illinois, we have one of the highest vaccine rates. So you can see that it can be done. You can overcome some of the challenges that have been brought forth through structural racism or gaps in income or challenges, and the numbers are there. So as much as we still highlight the challenges that we have, because we are on a road to improvement and have not reached the end of that journey, you can see successes, and you can see that things like mass vaccination centers, equity pop-ups, working in socially vulnerable communities, and helping to ensure that everyone has access through universal means can drive change. And that change is that one of the most diverse counties in the country had also one of the highest vaccination rates in our state and throughout the country, and led the way in how we can do that. So I think that we need to continue to do that. We need to continue to make medicine more available. And I think that will be the story that we take from this. And also a reinvestment in the need of our public health infrastructure, whether it's our public health departments or our safety net hospitals. I think we have seen that when a pandemic or a viral concern like COVID-19 strikes, sometimes things that we have often used as distinguishing factors to say, I won't be touched by that, or that won't hit me, or that illness doesn't really impact me, or issues of social determinants aren't my concern, quickly changes when illnesses that are communicable impact all of us, and we are all in the boat together. I think we need to take that with us going forward, that regardless of the health challenge, the social injustice, or the social determinant we're trying to address, in the very end of the day, we are all in it together. And what affects one affects us all. And we need to work on building a better system. And that's where we hope that we move into the future.
If I may, Steph, just briefly, I think fantastic points, Israel, and I agree with you that the optimism, the opportunity, and capitalizing on that. I just wanted to highlight one thing that I think is relevant, and it bears back to the walk a day in the shoes when we talk about telehealth. And not everybody, irrespective of the technology, one of the things that I saw repeatedly with patients was taking calls in their car, which in the first instance, you're questioning why on earth would they do that? But they live in a circumstance that has no privacy or no availability and end up struggling with this technology. Solutions to that are not technological, it's about physical presence and rolling it out. And I'm sure Jay has probably seen that in his practice. So technology is the supporting act, but providing the infrastructure that allows for it, I think, is part of that inequity solution.
And one of the things I will add is how we bridge it. So yes, we encountered that, but you pivot to things like phone, you pivot to drop-in clinics to do lab testing. When I think that I want to add that when telemedicine is part of it, I think we have to look at telemedicine and access points across it. Right now, and what we have seen, things like urgent cares, intermediate care centers are largely for private insured individuals. And unless we continue to address those inequities and find ways that individuals, despite their literacy or their physical challenges, can get access to this technology, we will never move the needle. So unfortunately, we can't just say that it doesn't work, that it's not available, that this time it can't. If our public systems can, and we do now through food and nutrition, give cell phones and we can get food stamps, SNAP benefits, enrollments to the most challenged individuals through mobile technology and means, we need to be able to have that same kind of capability for the systems, and we have to force our systems to work. I think the future of this is that we can't allow, and my fear with social determinants at times is that phrase gives people a way to say, well, it can't be done. Those populations can't be served. And that is the beginning of the end. We can never use words or factors like social determinants to say something is determined, because it's not. We have the ability to make the change happen, and we have to force it in every way that we can, and know that it is resolvable and we can address those challenges.
I would just say that this is a fantastic conversation, and I'll just start where Julie started in this notion that equity is a bridge to a better future to everyone in America, and I think that's spot on. And to see the administration make strides in significant ways, and there are a number of ways that they've done that. But I'll just raise the issue of healthcare affordability, which we haven't talked about, which is really important, and the ACA provisions from the American Rescue Act, and all the different provisions in the American Rescue Act that impact social needs, social determinants and health equity are critically important, and allowing those to, I think, improve that bridge to a better future. And I would say that partnerships, are critical too. And I've been fortunate to work with Israel and his team with Medical Home Network and Cook County Health System and our FQHCs and Rocha and Sinai and a number of other community-based partners. And that kind of interrelated collaboration is so critically important to drive health in these vulnerable communities. And 15 of 17 most vulnerable zip codes in Chicago, where the income is the lowest, is where we work. And I think that you can only get it done with those kind of partnerships. And say data and infrastructure modernization. So we've been able to use our platform in combination with data from partners and public data and claims and clinical activity to create a predictive model that allows us to prioritize care management outreach to patients who are likely to have a heightened vulnerability to severe complications or experience social isolation as a result of COVID or other issues. And we have dynamic risk stratification. So, someone's risk today may not be the same risk tomorrow or a week from now. And so how do we move between that to meet people where they're at, both figuratively and physically? and virtually. And then echo the public health workforce comment. And I think doubling down on addressing, how do we communicate more effectively, address misinformation and disinformation, because that is also critical training and needs for, I think, population. And then on telehealth, virtual and digital, that's not just for acute conditions, but for prevention. I think we miss the opportunity to use it effectively for prevention and think about digital literacy for the various populations we engage with. And then I think building upon the strong relationship between government, the private sector that drove innovations in supply chain, logistics, manufacturing, vaccines, treatments, and incident command, and particularly with our healthcare systems. I think that are important things to move forward. And I think that, I love this city, and I think it'll take another Burnham plan so that we thrive significantly post-pandemic and keep people here in Chicago and the surrounding counties, so that we thrive in a way that's sustainable and supports, the kind of vision of cutting the inequities gap in the health that we see on the west side or the south side, and across, our communities.
Maybe Steph, I'll just chime in quickly to add on to that. I think what Israel pointed out too is that the sense of fatalism is not something that we can accept, that we have to really look at this moment as an opportunity, that with this crisis, there is an opportunity to do more and to do better. And with some of the federal policies that we're seeing play out, whether it's the American Rescue Plan and some of the nutrition supports that were included, at least through this end of this year, eviction moratoriums, there's paid leave being considered, there's minimum wage, these kinds of policies. There's glimmers of hope that we haven't had in the past that really need to be seized upon and use what we've learned from the pandemic to really pave the way forward for a better, stronger future. So I totally share Israel's concern that we don't accept that these things can't be changed, but that we really need to move forward. And I see hope. I have hope and I see promise with some of the federal policies that are coming through, but it requires all of our advocacy. And so when I think about Dr. Yancey's slide in terms of what we can do in terms of advocacy and voting, these are all critical things that we need to do to really influence the policies that really make a difference in terms of whether we're better after this pandemic or we're the same.
Thank you, everyone. And I would be remiss if I didn't take this as an opportunity to let everyone know that this is going to be a really key topic at an all-in event later this month around rethinking space and place for point of care and really going in depth on how we can utilize the power of telemedicine for preventive care, for meeting the patient where they are. And as Nick so beautifully says, walking a day in their shoes and meeting them where they are. And that will be on September 16th from 11 a.m. for those of you who wish to join that. A little plug there. One of the top themes that's coming up in this conversation that I think is a great question to ask to you, Jay. We're talking a little bit about the national policy, some of the supports around funding, eviction and moratoriums, things like that. But at a local level in Chicago and Illinois, what policy changes do you believe are needed to create effective and long-term improvements in health inequities in Chicago and Illinois?
Sure. Thanks, Steph. I think would allude to some of what we've talked about so far. Policies that support economic mobilization and economic mobility is really important. Policies that drive reorganization and restructuring of environment in neighborhoods. We know climate change is a significant threat. We know that safety is a threat. We know that violence is an issue that we've got to deal with. And so how do we make it safer and support communities in that? I think the issue of access and broadband and ensuring that people have access if we're going to move further towards digital and virtual. And then I would say, taking a page out of the American Rescue Plan, some of the policies and so, that are there, and some of the policies that Julie just mentioned that make sense, not only federally, but certainly locally. And I think that I think it would make a lot of sense to build on the conversations that were had, led by the city. And I remember going into the communities, really led by community-based organizations to structure a conversation about, what are things we need to help move the community forward. And I think that can be useful to help us uncover other policies that might move us forward.
Thank you so much, Jay. I want to ask one final closing question to have each of the panelists respond to. But before doing so, I wanted to note a comment from audience member Yesenia Cervantes Vasquez. Thank you for your comment, Mr. Rocha. I often hear that it, quote, can't be done when it comes to our undocumented people. Yes, it can, and yes, it should, because they are very much a part of our functioning society. So thank you, Israel, but also thank you, Yesenia, for highlighting that. Community Health's mission is to do just that. And so I thank you for highlighting that and the comments today. So one final question, and we only have a few minutes left, so it's going to be a tall order for each of our panelists to respond succinctly. But Julie, let's start with you. How would you like to see healthcare change, adapt, and innovate based on what we've learned during the pandemic?
Well, that is a big question to answer, but I think it's an appropriate question to be answering. And I think I would like to see that there is affordable, accessible, high quality healthcare available to all throughout the nation. I think that's a critical piece, is just this access and affordability piece to healthcare. That without that, I think we will be left unprotected again with the next pandemic. So I think that is a critical thing that we need to see in place. I also feel like it's really important for us to be wise about the way that we approach solution building and have it be data informed. So having access to high quality data that are disaggregated by race, by geography, by economic, socio-demographic characteristics is critical to inform a way forward for us. And that not all solutions are the same for every entity and every location. So that there is high quality data that are informing responses, but then also that the community is involved with development of solutions and a better, stronger system that is in place. So I guess the key elements from my perspective are: number one, high quality, affordable, accessible healthcare for all. Number two, that the solutions, the systems that are built moving forward are really data informed with disaggregated data, so we really know who is most affected and who needs the most resources and what resources are needed, and then also that the efforts are really informed by the community and the populations that we're serving.
Nick, what are your thoughts on this?
Well, thank you, and I just want to call out Israel as well. I've been using SDOH for forever, and not once has it ever occurred to me that determinants, as the word in there, was just pejorative. And it's extraordinary to me that it takes this point of time to have that. The opportunities are boundless in my mind. My glass is always full. It's half full of whiskey in my case and half full of air, but I look towards the opportunities and capitalizing on what has taken place, learning from other experiences. Let me just close it with this basic premise in regards to this. The best available option is always available. Perfect almost never is. And we can always strive with small incremental steps. And I know everybody wants the exponential moonshot, and we should keep shooting for that, but we have to find those small changes throughout. Everything contributes, but we all have to be focused on it. And, as appropriately pointed out, words matter. I mean, I sit here humbled by that, quite frankly.
Thank you. Jay and then Israel, if you all could respond in around a minute or less.
Yep. So I would just echo the comments, that have been made, and I would say challenge is an opportunity for positive transformation. And I think if we miss that opportunity, shame on us. I think this is really an opportunity to come together, to move forward, and say, how do we amplify the things that worked and close the gaps. And do that together, and that we can't make assumptions about what we can and can't do, but we've got to have data inform that. and have a conversation. So I hope that this is one of many of those conversations. Thank you.
Just moving forward on that, I would say that every challenge, even our greatest challenges, present moments of opportunity. And I think the moment of opportunity that we have taken from this is to see how we can come together and how we can work collectively to improve something that is broken, that we fundamentally need to enhance, and make sure that everyone is included at the table for the resolution of how we can create healthcare for everyone in the way that they need it most, in an individual plan, but that collectively moves the improvement of healthcare. And I think this has reminded us, and if there is one opportunity from COVID, is that it reminds us that in healthcare, we're all in it together. And when we deal with things like communicable illness and pandemics, there really is nowhere that someone can hide, or no factor that protects you, or what social influence factor or party you are. Healthcare is everyone's journey. And when we are in it together and we realize that, I think we can fortify the systems that we need, invest in what we need to do, and make sure that we have a clear plan ahead of how everyone can live their healthiest life. And I think that can happen. And I think this is the moment that we have been given, despite the challenges and the loss. The opportunity is how we make a better tomorrow. And I think we can do that jointly.
Thank you so much, Israel. I think that is the perfect note to end on, because we truly are at Community Health all in it together. So we're out of time today, but I'd like to thank each of our panelists for your leadership, for your insights. This was truly incredible. I'm so grateful to each of you for joining us. I'll now invite Brian back up to wrap up today's program.
Wow. Thank you, Steph, and very much thank you to all of our esteemed panelists, not only for your time today, but for all that you're doing in our communities. What you shared was truly informative and really demands action. As I mentioned earlier, today's program was brought to you by Community Health. All of your ticket sales and any donations you make today will support Community Health's mission to serve those without essential health care. So please consider making a contribution to support Community Health. Instructions should be appearing on the screen now. And on behalf of the board of directors, staff, and volunteers at Community Health, I want to thank you all for being a part of the 7th annual All In Chicago Breakfast Summit. I hope that you're all leaving here today with ideas for how we can work together to make a vision of access to care for all Chicagoans a reality. We have 7 more events coming up throughout the rest of this month, and they're all free to attend. I encourage you to check out our website, allin-chicago.org, to learn more about the great events coming up and register to be all in. We all truly have a critical role to play in this effort, and I want to thank you all for being part of today's event. Hope to see you in the next sessions.